thanks everybody. Yeah, let's see, the clicker's right. We're going to cover a couple things here. First is a general thoracic surgery reimbursement, update, but then we'll also go into CPT coding. There's two parts to coding. You've got CPT, which most people know, surgeons are familiar, proceduralists are familiar with, which stands for current procedural terminology. But the other thing you've got out there is ICD, and everybody sort of knows about ICD-9. How many people know about the conversion to ICD-10? And your institutions certainly know that. That now has been put on hold, and it was supposed to go live October 1st of 2013 here, and that's been put on an indefinite hold, and the Secretary of Health and Human Services announced that. But most institutions, Mayo Clinic is not forgetting about it. Mayo Clinic's still going ahead, with all our systems changes. Part of the reason it got put on hold was just the expense. I mean, for Mayo Clinic, it was going to be well in excess of $50 million to convert to ICD-10. So the costs were astronomical, and industry was having trouble keeping up. I have no disclosures. I didn't badger you with RUC surveys, this time, but really I put this here to say a big thank you to everybody here, everybody in the General Thoracic Surgical Club. I mean, over the past 4 years, you've been inundated with surveys from us, and it's just important information we need, to validate these CPT codes and go to the RUC. And your voice has been heard. The General Thoracic Surgical Club is the representation for thoracic surgery, general thoracic surgery with the STS. So again, thank you. There's also a huge number of physician volunteers, primarily through the STS, that champion all these efforts. A big thank you goes out to Peter Smith, Peter's chair, cardiac surgery, at Duke. He's headed the workforce on nomenclature and coding for a long period of time. But again, general thoracic surgeons play a big role here. Cam's here, Keith Nonheim, Alex Little, Robert Lee, and myself, and just a huge amount, similar to other committees at the STS, but volunteerism is important. But again, thank you to you for helping us out. The reimbursement and coding maze, it truly is a maze. I mean, the big thing here is to work hard, understanding it as best you can, work with your coders, work with your billing office. The E&M sort of pie here, or how much money is on the table for cardiothoracic surgery, are E&M visits, your office visits and things do count. Makes up about $110 million, to total cardiac and thoracic surgery reimbursements. But obviously procedures, are fivefold that, $549 million. But cardiac and thoracic surgery in the whole Medicare Part B payment schedule makes up less than 1%. Imaging and other procedures is 63% of the pie. How have we done? Over time. This goes back to 2003 to 2011, and we can see that we've made a gradual increase, in our reimbursement. It certainly hasn't kept up with inflation or things like that, but there's overall cardiac and thoracic surgery. The red line is cardiac surgery. General thoracic surgery, has been relatively flat, but we haven't seen major decreases. The 5-year review took place, and these are some of the things you people were surveyed. It's a busy slide, but really just to focus on lung transplantation. Lung transplantation, was badly undervalued. It had RVWs, of somewhere between 40 and 60, and in the schedule that came out this year, those have increased, from 50 to almost just shy of 100. We pretty much got what we asked for, from the RUC and CMS, for lung transplantation. From a general thoracic surgery standpoint, there's suturing of the esophageal wound, sort of the Boerhaave tear. That had 28 RVWs, and that's now gone up to 44. So that too's been appropriately valued, and those are changes that went into effect this year with the final review. We talked about ECMO. I'm just going to touch real quickly on VAD, for people that might be or have people in their practice that are doing ventricular assist devices. Those codes, basically went down, in terms of their value. They went from 25, 30, 35, down. But the big thing is you'll see that they're known as what is XXX codes, meaning, that they're 0-day globals. So that's the big change, and for people to remember, is now with a 0-day global, you can pay or bill for, charge for, code document every E&M visit you do. So the thing that we're stressing, is to capture that through the E&M visits, and if you actually do the math for the number of days these people in the hospital, the number of visits that they take, they require, the actual value comes out the same or higher as the old codes.
Same is true for ECMO?
The ECMO code didn't change. So that's just the ventricular assist device codes. At the end of the day, though, okay, this is Peter Smith's slide. Okay, we do have a target on us, okay, from CMS, and both from a general thoracic surgery standpoint and a cardiac surgery standpoint. And as it says here, boy, that's a bummer of a birthmark. What have we done? Well, the lung codes, okay, went through the RUC process and the CMS process this year. Here are some of the codes, and we'll cover this a bit. We did not get what we asked for in a number of the codes. The CMS actually disagreed with the RUC on a number of codes. CMS has applied interim RVUs, okay, to these things. The biggest change we probably took was to the wedged resection codes, you know, down at about 15, 13 RVWs. We are appealing that, and we'll go through an appeal process with CMS, but it's a process that takes in excess of a year. The one thing about the wedge resection code, though, is it was probably overvalued to begin with because the descriptor prior to the change was for bilateral wedge resections. The actual descriptor was a median sternotomy, okay, with bilateral multiple wedge resections on the side, and most people haven't done that for quite some time. Paraesophageal hernias, okay, those codes actually got revalued over 2 years ago. What this graph, okay, shows is basically all the blue dots are cardiac and thoracic surgery codes, okay, some 150 codes that have been updated over the years, and you see somewhat of a linear, okay, line there, and that's where we like cardiac and thoracic surgery to fall. The red was the old paraesophageal hernia codes, hiatal hernia codes that we updated. The triangles were actually the RUC recommendations, so the RUC recommendations followed this line a bit, but then you see the yellow, and there's where CMS is, okay, and CMS basically changed the values below the RUC recommendations. That went through a process called the refinement process. CMS still disagreed, so there's now a process called rolling refinement, and we'll continue to push for getting those codes valued at least what the RUC recommends. So where are from general thoracic surgical coding, okay, what people need to know about in terms of the new lung codes. There's no absolute on who should do CPT coding for surgical procedures. The optimal coding situation is an interactive collaboration involving the surgeon and their coder, and this allows for the best prospect for compliance and for most favorable reimbursement. How many people here actually own or have access to a CPT book? Okay, that's good, because I mean a number of groups, and particularly in academic groups, I mean they leave it to their coders sometime and don't follow what's going on. But I encourage you, okay, to, particularly for the lung codes, look at what it says in terms of the new lung codes. The descriptors are excellent, okay, the parentheticals have been well written, and if you just follow the wording in the CPT book, you'll be fine. This just talks about accurate and compliant coding with recognition of the revenue, and that's what this is about, but it's the revenue you're entitled to, no more, no less. Documentation is the key. Along with documentation is proving medical necessity. You have to be aware of global periods, okay, and that's where there's array. Most people think of 90-day globals, but we have a number of codes out there, VAD I just mentioned, but the thoracoscopy, the diagnostic thoracoscopy codes are 0-day globals. We also have some 10-day globals, so it's things you need to be aware of. There's a thing called bundling edits. Simple example would be a chest tube. If you do a thoracotomy and a lobectomy, you can't bill separately for the chest tube. That's included, okay, in what we do. There's a variety of modifiers, and then you're also limited to both your insurance companies, okay, and HMOs that you're dealing with in terms of their rules and regulations, but also local Medicare carriers. This basically just talks about the global period. XXX codes are 0-day globals, and then there's a thing out there called ZZZ codes, and those are add-on codes. And the best and most well-known add-on code we have is probably the lymphadenectomy code. Okay, when you do a lymphadenectomy at the time of thoracotomy or thoracoscopy, there's an add-on code for the lymphadenectomy. The global period. A global period is initiated when a CPT code is billed and defines a period of time where other billing related to that service described by the CPT code is prohibited. Okay, and that's because they've already been valued, including those other things, but the example there, okay, would be a lobectomy. Or, okay, if you do a lobectomy and basically from the day before until 90 days after, you can't bill things, but it's not necessarily the day before. It's when you've decided to operate on the patient, okay, that this thing starts ticking. So if you have decided a week ago you're going to operate on the patient, see them the day before, you can't bill for that. If you're actually seeing them the day before, which we see a lot of, and getting test information back, their CT scans, their PET scans, blood work and things like that, that can be billable as an E&M visit, even though it's the day before. Short global periods, okay. Here are things that have 0-day globals: bronchoscopy, thoracentesis, indwelling catheter, which is actually the Plurax catheter. Those all have 0-day globals. So E&M visits can be billed from the day after you put the catheter in. Chest tubes, pleurodesis, fibrinolysis, okay, putting basically chemicals in, obviously, to unplug Plurax catheters or chest tubes. That can be billed, okay, with a CPT code on a daily basis. The diagnostic thoracoscopy codes, those all have 0-day globals. We actually lobbied CMS, okay, to make them 10-day globals, make them similar to mediastinoscopy. We thought we might save them money, but at the same point in time make it easier for physicians to deal with this and remember. And CMS came back and said no, they wanted 0-day globals. So the diagnostic codes, not the therapeutic thoracoscopy codes, but the diagnostic codes are 0-day globals. And then sitting out there is mediastenotomy. A Chamberlain procedure actually has a 90-day global, so it's different, okay, than mediastinoscopy or the others. Additional procedures performed in the post-op period. Certain things, okay, can be billed for. This slide really, best one is bronchoscopy. If you do bronchoscopy and it's done for an indication, if it's done in the ICU or the patient's hospital bed, that's part of the global period. You can't bill separately for it. But if you actually do it in an operating room or a designated treatment room, okay, for secretions and things, that is billable. And there's a modifier 78 that you use for that. And then new and unrelated problems for E&M. Okay, certain things are included within the global period, but the example we give here is if a patient with a known history of DVT develops a pulmonary embolism in the postoperative period, requires extensive critical care time that you're providing, you can actually bill for that using the E&M codes, the critical care E&M codes, as a new problem. That's not included in what people think of doing lobectomy, pneumonectomy, etc. However, those modifiers are the 24 and 25 modifiers, and if you abuse those, okay, that has triggered audits of various institutions and physicians. 51 modifier, most people would know that. Best example, lobectomy and mediastinoscopy. I mean, if you combine procedures, certain procedures can be combined. The highest billable procedure gets 100%, but everything else gets 50%. Here are the lung and pleural changes. I gave you a handout, okay, that you can take with you, and I think that's a good summary. Julie Painter from the STS helped put that together. But really what that handout shows is the deleted code and the old term and what this now maps to. So on the right-hand side are the new codes and how these things map, and I think you'll find that useful, and we'll go through that in a few seconds. But the new codes basically get rid of obsolete services. There's clearer service identification. Procedures now are broken down into percutaneous, VATS for video-assisted thoracic surgery, and thoracotomy. Tissue location and types is accounted for in the new codes, and surgical intent. And this is the first time this has really been done in CPT, and they lauded us, okay, for doing that, is you have both diagnostic and therapeutic, okay, built into the code, which has always been a problem for the lung biopsies. There's a bunch of deleted codes, okay, and you could just read through those, but they've all then been replaced by the new codes, which is really what we want to focus on. Wedge resections, okay, are classified now as diagnostic and therapeutic, and the biggest thing you can do, again, is read the sheet I gave you, okay, or look at the CPT book, and in your operative dictation, tell your coders, okay, tell people what you're doing, whether your intent is diagnostic or therapeutic. Segmentectomy, lobectomy, and bilobectomy now, pneumonectomy, there are some changes that went on there. There's been some changes in intraoperative pathology. Actually, they call it parentheticals. They're now well defined on when you can use intraoperative pathology and when that can be billed for separately. And there's some other add-on codes. But some of this led into the lung biopsies, the lung infiltrate, and I think we'd all agree that doing a wedge resection for a lung infiltrate, whether you're doing it with an open thoracotomy or thoracoscopically, is easier, okay, than finding the little nodule, okay, sitting on the side or another nodule deep within the lung. And what we tried to convince CMS, okay, and the RUC and the CPT panel about is no, you got to put extra work, effort, finding that nodule, taking that nodule out with free margins, much like a sharpshooter, as opposed to, you know, when we're doing the lung infiltrate, you could basically biopsy the lung most anywhere. And I think the best thing we can do is just look at the sheets, and I'll walk through those, okay, with you. The top part of the sheet talks about the thoracotomy, okay, codes, And then it's almost a mirror image thing with thoracoscopy. But you can see 32095, thoracotomy limited for biopsy of the lung or pleura. The word limited is now gone. Okay, I never quite understood limited thoracotomy from thoracotomy, so limited is gone. But that particular code is now replaced by thoracotomy with diagnostic biopsies of a lung infiltrate. You know, so what you want to tell your coders, what you want to put in your documentation, is that it's a diagnostic biopsy and lung infiltrate. You put that there, it'll get coded right. But you also have thoracotomy with diagnostic biopsies of lung masses or nodules, and we give examples, wedge resection, so it doesn't matter whether you use staples, whether you use incisions, okay, whether you use electrocautery incisions. And then there's thoracotomy with biopsy of the pleura. And again, biopsy of the pleura is a lot easier than doing either of the lung biopsies. Biopsy of the pleura, okay, then also maps right across. But then you have removal of the lung other than total pneumonectomy, wedge resection, single or multiple, 32,500, probably the workhorse of what we do. And the term total pneumonectomy went away because I don't know what is total about pneumonectomy, so we sort of cleared things up there. And now you have thoracotomy with therapeutic wedge resection. Example, mass or nodule, probably the best example would be pulmonary metastases, when you're going after colon metastases, renal cell metastases, etc. And there's an initial, but then we also have an add-on code for the additional metastases that you take out. So you can apply that add-on code. Now, these are interim values. CMS is going to be watching this. The median number of metacystectomies that's done based on the literature is between 2 and 3. And that's what we told them, and they're going to be watching for that. Now, Ara, you and I were talking, and certain times we come across and you'll take 7 metastases out. I've certainly done that for renal cell cancer. But we've got to be careful with how we code this and use the code honestly and appropriately. And again, based on the literature, we told CMS that it was the median of 2 or 3. And then there's basically diagnostic wedge resection followed by anatomic resection. Example being, if you do a wedge resection of the lower lobe of the lung followed by lobectomy, you can now have a code for the wedge resection followed by the lobectomy. And that's something before that you couldn't code for or bill for. Thoracoscopy codes, starting with 32602, right in the middle of the page, basically mirror image the open codes. So we made it easy that way, and the only exception would be is if you do a VATS diagnostic, okay, or therapeutic wedge resection, followed by an open procedure. There's that combination too, and that's built into what you call the parentheticals. So if you're looking at the codes in the CPT book, they tell you, okay, what to bill for and what not to bill for, what codes can be used together. And that's just that part of the page right there. So I think the pages should help you out. Page 2 basically then just talks about new codes that we created. There's thoracoscopic segmentectomy now. There's also thoracoscopic bilobectomy, for which there wasn't a code. Thoracoscopic pneumonectomies are being done. I mean, we all talked about shying away from pneumonectomies, and it's a bad operation, but they are done. There's now a code that's been created, okay, for that. Thoracoscopic LVRS, okay, and then also basically resection of the thymus thoracoscopically. The other add-on code there, 32674, is mediastinal lymphadenectomy. The mediastinal lymphadenectomy code had really been an open code. There's now add-on codes for both open and thoracoscopic. And then the bottom half of the page is just really some descriptor changes. Total pneumonectomy went away. Removal of lung other than total pneumonectomy, single lobe. So those are just word changes. So in summary, the coding changes, I think, cover most clinical scenarios. Documentation is really the key to determining the correct code for several procedures. If you read and pay attention to the guidelines and the parenthetical notes that are in the CPT book, they really tell the story. Just a little bit on hiatal hernias. Those codes were actually new in the 2011 CPT book. I think we now have codes reflective of the type of hernia, the surgical approach, type of fundoplication, and procedure modifications. The big thing here is you've got your sliding hernias and your paraesophageal hernias. Again, in your documentation, differentiate between just the sliding hernia or the paraesophageal type hernias, and there's codes, okay, there that reflect that. Here's a fundoplication, okay, basically laparoscopic. The big thing here is 43282 in the middle of the page is now a mesh code. Some discussion happened last night, you know, about should we be implanting mesh or not. Okay, we certainly shy away from mesh, and can talk about the cases of mesh eroding into the esophagus. There is a mesh code now that exists for those people who do implant mesh. There's also basically the thoracotomy approach. We've separated out if you're doing open procedures, open laparotomy and hiatal hernia repair versus thoracotomy. So there's codes that cover the approach. And you also basically have that with and without mesh. And then there's also basically thoracotomy and thoracoabdominal incisions. So again, the approach is now part of the hiatal hernia codes. And then gastroplasty is both an open gastroplasty code and a thoracoscopic, okay, or laparoscopic gastroplasty code, and those are add-ons, okay, to whatever type of repair you're doing. The TIF procedure, we've been getting questions about that. There is no code for that now. It'd be inappropriate, okay, to use a laparoscopic code for the TIF procedure, so the recommendation is what's known as 43499. It's an unlisted stomach, okay, code at the present point in time is the recommendations we make for that. Coding resources, there is a thing called the STS coding hotline. As members of the STS, you get unlimited, okay, calls to that number, or basically the best way to get a hold of Julie Painter is to email. And then she works on getting answers to the questions that you or your staff have. Those questions oftentimes get sent out, okay, to Cam and Keith and I, and we respond back. There's also the STS annual coding workshop where at least 200 or so some coders and physicians attend, and that's in October, November time frame of each year going through these changes. Thank you.